Hello, everyone. Welcome to impACCT Virtual Round. It is my pleasure to introduce Dr. Jim Wright, our first session facilitator. Dr. Jim Wright is the head of the Integrated Radiation Treatment Program at the Javinsky Cancer Center. He is also currently the chair of the CCTG's Data Safety Monitoring Committee and also sits on 3CTN's Portfolio Committee. So now I would like to pass the session to Dr. Jim Wright and the speakers.
Thank you, Rebecca. The only problem with you doing a really good job of introducing me is that I don't have the ability to read everyone else's bios to the same extent. So people can introduce themselves with a bit more detail if they feel it's necessary. But the purpose of these rounds is really on a quarterly basis to provide some insight into some trials that are really managed within the portfolio of the 3CTN. And so we've tried to pick a collection of trials that really span disease sites and span the country, and trials that we think should be fairly not only important, but relatively easy to recruit to. And so we're highlighting these trials, and the investigators are going to present those trials for us. If there are questions about operational issues and how best to manage recruitment, that's really our focus. We have three speakers, all very experienced trialists. Dr. Meynard is going to go first, followed by Dr. Olson and Dr. Perry. So we're going to ask questions of the presenters after their presentations, and there should be lots of time to do that. So first is Dr. Meynard. She's coming to us from Montreal at CHUM and is going to present on her study that's dealing with PSMA scans in prostate cancer. I think in part it's the larger theme of trying to individualize treatments to patients based on really the characteristics of the disease, as we're discovering more and more with newer technologies. So I hope that introduction is sufficient, and I will leave it to you to present your study.
Now please turn on your microphone.
I had clicked it. Sorry about that, guys. Okay, share screen. So thank you for the introduction, Dr. Wright. Cynthia Meynard, I'm head of department at radiation oncology at CHUM and the PI for PATRON. PATRON is a randomized clinical trial phase 3 that will run across Canada, funded by used to be Prostate Cancer Society, Prostate Cancer Canada, now Canadian Cancer Society. We're very grateful for the opportunity to present here. The trial was activated in January of 2021 here at CHUM, and I'll give an update on progress for activation across the country. So next slide. So I'm going to start by pointing out that this is not the first trial randomizing patients to get advanced imaging prior to, in this case, radiotherapy. The site that beat us to the punch was Emory with flucyclovine, presented at ASTRO 2020, published in the Lancet in May. And this trial was a much smaller trial in a subset of patients receiving radiotherapy after prostatectomy and salvage of biochemical failure, with admittedly a different radiotracer than would now be considered standard of care, and also different radiotherapy practice, but nonetheless was able to demonstrate an improvement in failure-free survival at 5 years. And so instigated a lot of enthusiasm towards this avenue moving forward. Now here at CHUM, we had initiated in 2018 a phase 2 randomized trial of the PSMA PET PYL radiotracer in partnership with Progenics at the time. And this phase 2 trial has completed accrual, was presented at ASTRO last year, and was the data that permitted us, sorry for this, get rid bit of the phone call, was a trial that permitted us to secure funding. So there were 253 patients randomized between CHUM and Laval. And these were all patients that were destined for definitive radiotherapy, be it patients in salvage of biochemical failure in the post-op setting, high-risk patients, oligometastatic patients, or in salvage of radiotherapy failure. The two big cohorts being, of course, post-op and high-risk. You'll see here the distribution in the cohorts and patient factors, but the control arm and the interventional arm were equally distributed, both in patient factors and in therapy factors for the most part, with one exception, was the use of hormone therapy in the oligometastatic cohort in the control arm. So overall, we found that just under 50% of patients were found to have new lesions detected on PET in the arm, of course, that received PET that were not previously known, that resulted in a change in radiotherapeutic management. What we have not yet reported is the nature of the intensification, and that's the subject of analysis now, and also the outcomes related to the intensification of treatment. In the post-prostatectomy cohort specifically, you can see that most of the positive new lesions are found in the pelvic lymph nodes, with a subset having oligometastases and another subset recurrences in the prostate bed, but admittedly a much smaller proportion. What was reassuring is the yield between a PSA of 0.1 and 0.2 was about the same as it was at higher PSA levels, giving us confidence of the performance of this technique. Sorry, let me go back, even at low PSA levels. In the high-risk cohort, it was a little bit different. We still found pelvic lymph node metastases in the majority of those with no lesions detected, but a much higher proportion of patients with oligometastases. And in fact, a subset here of patients with wildly metastatic disease that were no longer appropriate for local radical interventions, local regional radical interventions. Sorry about that. In the oligometastatic cohort, all of them were found to have new oligometastases, but none were found to have wildly metastatic disease, which is also an interesting finding. We did look at toxicity and overall find no difference in the rates of grade 2, grade 3, or grade 4 adverse events in the control versus the interventional cohort. There are some events that are attributable specifically to the intensification of radiotherapy, however, at least 2 that are considered severe. So this led us to PATRON, and this is the schema for PATRON. Has randomized to date 67 patients of a total of planned accrual of 776 patients, and this is over 3 years. So we have a lot of work to do in the next 3 years to get there. Of the participating sites, 3 have been activated to date, all 3 in Quebec. But in the next 3 weeks, there are 7 more activating, which is good news for us. And hopefully by the end of the year, we'll be activated cross-country wide. Let me go through this schema. It was really designed to be a very pragmatic trial with broad eligibility, and I'll go through the eligibility as well in a second. But it's any patient with prostate cancer that are considered at elevated risk of undetected metastases, but that are M0 unconventional imaging. And this is prior to embarking on a treatment of either radiotherapy or radical prostatectomy. So they fall in 2 broad cohorts, either the newly diagnosed high-risk patients that are not yet treated, and the criteria for high risk is a CAPR score of 6 or more, or clinically N1 unconventional imaging. For those in salvage of biochemical failure after prostatectomy, they have to have a PSA of greater than 0.1. After they're registered, you lock in your standard of care treatment plan based on conventional imaging, and then patients are randomized, and half will have the PET scan prior to treatment, followed by intensification according to the PET results, or the control group that will proceed as planned. Primary endpoint of the study is failure-free survival at 5 years. So the next slide describes all the different objectives of this trial. Failure-free survival here is defined as any failure and we expect the vast majority of patients on this trial to have biochemical failure as a first event. But we are measuring other things like toxicity and quality of life to reassure ourselves that the nature of the intensification we're proposing here will not result in undue added toxicity for the patients that are intensified. And we also have a cost effectiveness component that will try to determine the value added in terms of cost effectiveness of integrating PSMA PET at this stage in the management of patients. So here's the eligibility. As I said, very, very lenient. So we need pathological confirmation, meeting the risk criteria as I've described them. And then two key exclusions. The first is going to be the most common exclusion that we'll meet, is that patients cannot have started hormone therapy within the past 12 months. And that needs a little bit of sort of feedback to the referring base and more education across the board with regards to the fact that once hormonal therapy has been initiated, we lose a lot of opportunities, namely the opportunity to do a PET scan in this setting. And so that's going to be challenge number one. The second is that PSMA PET scans are becoming available to patients in Canada in the private sector and or provincial registries. Now, we've aligned ourselves quite well with the registries in BC and Ontario, and the overlap is really considered minimal, but the private clinics are what they are, and it is expected to only get worse as the trial proceeds. So we need to do this fast. Regulatory approval for PSMA PET with the PYL tracer has not yet occurred in Canada, but it has occurred in the US, and will certainly occur during the conduct of the trial. Clearly, we don't want crossover. So patients that are randomized to a control arm must be discouraged from obtaining PSMA PET scans on the outside. And if they do, physicians discouraged from intensifying the treatment accordingly on study. Trial SYN 5 or less is rather permissive, I would say, and obviously they can't have metastatic disease on conventional imaging. And that's basically it. Everything else is permitted. And treatment is really per local standard of care. The guidelines for surgery are very broad, as they are for radiotherapy, and really encompasses all the various practices across the country. Now, what we do with the PET scan is a different story. It's very prescriptive. It's not at all, you can do whatever you want. Specifically, if there's no new lesions, then there's no change in the treatment. No de-escalation of treatment. For example, if there was a plan to treat the pelvis, you still treat the pelvis even if the PET scan was negative, etc. So this is not a de-intensification trial. Majority will be new lesions in the pelvis, whether in the prostate bed or in the lymph nodes. And here you need to treat regionally as well as boost in the case of radiotherapy to make sure that all disease is targeted in a radical fashion. For oligomets, you still proceed with your plan for local regional treatment plus treatment to the oligomets if they're amenable to ablation. And finally, if patients have wildly metastatic disease, and this is expected to be very much the exception on this trial, then it's no longer appropriate to proceed with local regional treatment as planned. Radiotherapy to the prostate only is permitted per Stampede, but hormone therapy now changes to continuous hormone therapy management with or without maximal systemic therapy. So you'll note that there's no change in systemic treatment, hormone therapy in any of these arms except for the wildly metastatic arm. The only thing that is intensified is either the radiotherapy or the surgery. And these are the radiotherapy guidelines in terms of target doses. But you need to understand that as much as we aim for these higher escalated doses for ablation, what trumps all is dose limits to organs at risk to limit the risk that we will end up with higher toxicities on this trial. And it's not the only trial in this space that's active now. Indicate is another trial that poses a similar but different question from, I believe, Akron. In this case, all patients receive imaging. The first arm with pelvic-only disease are asking a systemic therapy question. those with oligometastatic disease are asking the merits of proceeding to SBRT to the oligometastases. So this is another trial in the same space asking a related question. That's all I was going to present to you, and I'm open to questions.
Thank you. Thank you very much. I don't see questions to this point. Maybe as a facilitator, I can start. I would imagine it's a huge can of worms to talk about the issue of instituting hormonal therapy once you have evidence of progression in these patients. Does the protocol have much in terms of suggestions for that? I ask because in part I would think that the biggest advantage really is delaying the need for essentially palliative hormonal therapy, if that makes sense.
Yeah, so what you do after we meet the primary endpoint, I think that's the question. Once patients fail in this trial, how are they to be managed? And that will be per standard of care management. We don't have prescribed guidelines on how that is managed. We assume a lot of patients will end up initiating hormone therapy. We do encourage that patients complete their conventional staging at the time of biochemical failure. PSMA PET at the time of failure as a staging tool is permitted on the trial, but it doesn't replace conventional imaging and doesn't count as an MFS endpoint by itself, just to prevent there be a bias between the two arms. I don't know if that answers your question.
Yeah, no, and I think the other piece, I think you answered this actually very well in the presentation, has to do with, I think, the challenges we often face with technology and radiation, which is to take a very hard line and say that it's not available. You're kind of stuck in the middle because of the private clinics that offer this. But I guess my question is, are there other kind of key points that are coming up in the process of obtaining informed consent that are the real sticky points with this, or is it really just about the PSMA scan?
You know, so far, the feedback that we've had has been very positive. Accrual's been fast in the 3 centers that have been activated. The only sticking points that have come up is very much the hormone therapy, that patients are referred already on hormones and are automatically non-eligible. But the other issue is being very hyper alert about this other mechanism of getting a PSMA PET scan, at least in the Montreal region. We've had a few patients that are very well informed, and we're clearly using this as a mechanism to get a free PET scan. And as soon as that kind of red flag came up in conversations, we had to be very aware of that and make it clear that the trial was not going to be for them in that context. So it's a tricky, that's been tricky from a consenting perspective, but the rest, the intensification part, nobody has raised any issues on that side of things.
Maybe my last question is there somebody in Hamilton I should be leaning into? Are we on the list for opening the study?
Yeah, St. Joe's is active. As of tomorrow, St. Joe's will be active. Dervinsky will follow hopefully in a few weeks from the radiotherapy part, but the surgical patients are go for next week.
Well, that's great, because I'm not in this disease state, but my sense is it's a bit of the Wild West with how we're actually utilizing the technology at this point. So I think it just reinforces the need for good research. So, well, if there aren't any other questions, we'll let Dr. Meynard move on. I'm not seeing very much. Thank you very much again. It was an excellent presentation. Good luck. And next we have Dr. Robert Olson. So we're kind of getting to the other side of the country. I guess it's barely past your breakfast. It's getting close to 10 o'clock. I think the other point I've noticed reading through all of our bios is we have too many people that should be doing clinical research getting stuck doing administration, but head of radiation, head of therapeutics at UBC, I'm going to hand it over to you for your presentation regarding oligometastatic disease. So a little bit of a slightly different issue, but relates in some ways to some of the issues Dr. Meynard has just been through. So I'm going to mute off, and again, if people have questions, we can ask those at the end.
Great. Thanks for the introduction. It's true, I do have lots of administrative hats, but I do enjoy that as well, and I'm trying to stick them towards research more and more. So I'm from BC, as you said. I'm from one of the smaller centers probably in Canada. I'm from Prince George, which is in northern BC. At least 8 hours to drive to any of the other centers. And so part of one of my themes is also to open up trials that are practical, that we can accrue patients from rural areas. And so yesterday, my clinical trials manager was talking about how 3CTN has worked with us on craft, specifically in this study. So as an advertisement for you to watch that slide, or those slides you haven't yet. So this study has been funded by CHUM, which isn't really a disclosure, but Varian makes linear accelerators. So as background, Sabre Comet was a randomized phase 2 trial that David Palma in London led, and I obviously was part of as well, that some people call it like paradigm changing or a landmark study, although I would say it was a pretty small phase 2 trial, so probably getting a little more hype than it deserves. Sorry, Dave. But it did suggest an overall survival advantage to Sabre, but it was powered to see if we should go to phase 3 trials. And the p-value supported that. So certainly, like I was actually a bit of a naysayer and joined the team mostly because I was a skeptic. But anyways, the results convinced me that we should go to phase 3 trials, although some people have interpreted that as treating off trial internationally. Anyways, to stick with the pure academics, we did plan to follow up phase 3 trials. So Dave's group was a little bit more on the believer side, so they thought they would have a hard time accruing 1 to 3, and so he's leading Sabre Comet 10, which is 4 to 10 metastases, while I'm leading Sabre Comet 3, which is 1 to 3 metastases. So we sort of split it that way with a lot of similarities, although his radiation doses are a little more gentle and a bit more, even more practical. So the primary objective, like the phase 2 trial, was overall survival. As I said already, it's 1 to 3 metastases, which actually does sort of line up with the original trial quite well, because the original trial mostly had people with 1 to 3 metastases, despite it being eligible for 1 to 5. And then several secondary objectives that are all mentioned here, which are kind of standard. So we powered it, so it's about 3 times the size of the original Sabre study. That's part of CIHR feedback, was for me to increase my sample size, which is difficult when you don't have a lot of money. And so, but anyways, we've now think we have sufficient power with a sample size of almost 300. And we chose a randomization that was quite popular with Comet, which is 2 to 1 Sabre, because so many people are being referred to us essentially for Sabre, and it's hard pill for them to swallow, knowing that they might be referred to not even get any treatment, because standard of care, if you have no symptoms, is often no treatment. So clearly, if you're referred with a bone metastases that hurts, well, the standard of care would be palliative radiation. But someone who has an asymptomatic 3 lung metastases, often the standard of care would actually be just systemic therapy, and so that's what we are doing. We learned from the original Comet study that instead of having just everyone and no stratification, well, actually they stratified by the number of mets, and most people had 1 to 3, as I said, so it didn't actually end up being much of a stratification. We introduced histology and disease-free interval, because both of those are well associated with overall survival. So we wanted to ensure they were evenly distributed. So I just have some simplified inclusion criteria here. So the life expectancy is greater than 6 months. Histology is confirmed, although we don't need to biopsy the metastatic disease. There's a little bit more nuance for some of the sites, such as lung metastases, where we actually require a PET scan, for example, just because there's so many cases of people having benign lung lesions. They do have to have a controlled primary tumor for at least 3 months. And so we do find quite a bit that people approach me saying, oh, I've got this prostate cancer patient with a bone met. Can I accrue them? And essentially the answer is, well, actually you have to treat the primary and then restage them in at least 3 months, which can be a bit of a difficult situation, knowing that they could get randomized to standard of care, and then would you have actually treated the primary radically? So like some scenarios it's more obvious than others. But anyways, that is one of the things that I get emails about. And then for the, I've sort of already alluded to the arm 1. So it's following the principles of palliative radiotherapy. So like actually quite a few of the times people are getting nothing when they are randomized to standard of care. I like anecdotally from my own patients that I've randomized, some of them find that quite difficult, and they find a way of asking, well, shouldn't I maybe have my lung lesions treated? This one kind of is hurting. So we're trying not to do sort of like Saber Light, where people do, 35 and 10 or 40 and 10 with 3D conformal radiation. So we're trying to control that so that it doesn't dilute the effect. And then so like, essentially we're recommending people get singles if they're getting bone mets, for example. And then systemic therapy is pre-specified based on standard of care, and it can include systemic therapy on either arm. Like this is like totally not interesting to medical oncologists and others, but essentially the summary is that it's very similar to Saber, and this is our standard in BC, and I think it's like quite supported and taken from other people's, like nothing really stands out as being unique in our dose and fractionation. So that's what arm 2 looks like. And this was already alluded to in Dr. Meynard's talk with hers, is that, again, organs at risk are really important to us. And so we're even being a little bit more careful on this in comparison to Saber Comet, though Saber Comet also put a high priority on this. So for non-RADONCs, what I'm saying is if we're treating, say, an adrenal met close to GI organs, the GI organs are more important than the adrenal met. So we're okay with underdosing our targets in order to make sure we're safe. And part of the reason is for that, which is a good reason, is that on the original Saber Comet, there was a 5% mortality rate, and lots of discussion could go into that if that's an overcall. And so we really don't want to cause deaths, obviously, or grade 3, 4, 5 events. So I'm presenting, sorry, this is a little bit of a divergence, but Saber 5 is another study that I led, which was after we closed Saber Comet, while we were waiting to open Saber Comet 3, and I'm presenting that at Caro next week, and at Astro in a month. And we actually found that our toxicity was quite a bit lower than the original Saber Comet study, and essentially using the exact same dose and fractionation that we're using for Saber Comet 3. And so we think that we're going to be quite a safe dose on the interventional arm if anyone has any concerns, but tune in to Caro next week. This I just took from our training slide. You're not supposed to absorb it right now. This is, but it is useful just to show that we tried to make it as pragmatic as possible because we don't have a huge budget. Like this is not being funded by a drug company, and so, but still there is quite a few things that are being collected throughout. So anyways, it's about as pragmatic as we could make this and still have high quality. Is essentially what I'm showing. I think this is probably the more interesting part, and I have very few slides left. Looking at the accrual, so it is certainly going slower than anticipated. So we're at 15%, a little higher now, closer to 20% accrual in over a year. So we were hoping to be much higher than that, almost at 50% by now. So like obviously I can blame COVID a little bit. Also, we started out with very few sites thinking that we could almost accrue mostly in BC, and we've decided to expand past that. We've had quite a bit of difficulty in Vancouver with their new EMR and COVID. And then it hasn't opened yet in Surrey or Abbotsford. And so we started opening other places. London opened up and accrued really fast, despite them being skeptical that they could, because they thought that their radiation oncologists were believers already and would be treating most people with 1 to 3 mets off study. So that's encouraging if you think that your site wants to open it, but that you're already treating. Well, clearly London is able to find patients that they have equipoise and are willing to randomize. And now we're opening quite a few other spots in Canada. And I've had some emails in the last couple of days of other people who want to open, and I'm even happier if people that are listening now want to open in their center and they haven't. We have expanded internationally, which has been a lot of work, and I hope it's worth the effort. But it looks like it is already starting to be with Australia accruing 2 patients. And there seems to be a lot of promise in the UK, people accruing as well. So we're crossing our fingers that our accrual curve will be exponential. I think I have to draw it this way for you, which it often is in clinical trials. And so I just kind of been waiting for that inflection point to happen because it hasn't quite yet. So this is my last slide. It seems like I'm ending on a bad note, but some of it is that we've overcome these challenges. So I'm trying to end positive as well. So funding has been very difficult for radiation trials. Because I sit in leadership positions and research, I'm just like always astounded on the numbers that we're talking about in comparison to systemic therapy, where it just feels like we are in kindergarten compared to the people in university, with the amount of funding they're able to accrue or able to attract, but we're not. So I have put a lot of effort into getting funding for this trial. Before this trial, we had a randomized phase 2 that was in the Lancet. You think this would be an easy win to get funding, and it's been quite hard. So thankfully, one of the the linear accelerator companies is partially funding it, CHR, and then our local foundation. But it's still such little amount of money, around the $5,000 mark, that some centers are choosing not to open it based just on that it's going to be money losing based on the amount of work that is being set into it, especially the translational component, which I have as another bullet. COVID has slowed things down, but everyone has the same reasoning. In BC, this actually really surprised me for how big BC is, that we were actually the first international trial where we were acting as the sponsor, because apparently whenever we're leading international trials, it's through drug company studies and they're the sponsors. And so they're doing all of the legal work. And so it required BC Cancer to get additional insurance and learn things that are well over my head. So that's been a big deal. Very similarly, contracts at the international sites have been quite complicated. And thankfully, people are, like Lindsay Matthews, who works with me, has been doing an excellent job of shouldering a lot of that responsibility with our legal team. But it has been quite a bit of work, but I think necessary in order to accrue in the next 3 years. As I already mentioned, the translational component has been quite difficult given the cost to collect blood and ship it versus the small budget that we've got, especially because we're trying to do, it's the multiple draws that really get you. And this is actually a new process for some centers, including where I live in northern British Columbia with this, our local health authorities, Northern Health, which we have to partner with. And we're the sponsor. You'd think that this would be easy for us, but this has been a lot of work. And so probably our first 15 patients or so didn't have any of the translational component because it took us that long to get things going over a year or so. And then we still do have the issue with some of the patients who have solitary metastases are not being approached on study. In BC, we used to have a mandate that you could only treat oligometastatic disease on trial, and we have since made an exception for very well-selected solitary metastases, even more strict than the study, who are allowed to get it off trial. But that is actually bitten quite a bit into our accrual in BC. So I'm sure that's going to be an issue everywhere else as well, as there's sort of a scope creep, even without phase 3 trials. So that's all I've got. Hopefully that wasn't too fast, but open to any questions.
Thank you very much. I have to admit, as you know, when we first started this, my camera wasn't working. The entire system kicked me out, and when I came back on, my camera's working. So I may have missed this. That's just basically to justify my question. And so do you have a sense, though, of where the primary sites are for this? I guess what I'm interested in really is, you know, are you at a point where you're competing a little bit with the PR20 CCTG trial? Is your population mostly prostate, or is it mostly everything other than prostate? Do you have a sense of that?
Yeah, so it's a little bit lower. So prostate is still part of it, but prostate is less than it was in Sabre Comet, if that makes sense.
Yes.
And that there is some competition, but so we've made it pretty clear in BC that we actually support the academic concept of specific trials, and we are making this because we were sort of pioneers, but also because we're a bit afraid that some of those won't accrue well. But if they are accruing well, we actually say we would prefer you accrue to PR20 than to Comet 3. But yeah, I think it's going to slowly, less and less prostates will probably be accrued.
Well, if anything, I would say I share your bias. In fact, I think this work is so important in terms of directing, you know, the use of resources really over the next generation, that these are really, really important studies to do. And so at some level, you know, it strikes me as the type of research that even government should be, you know, happy to support, because the answer is really just so important. If we don't do good research, I have no doubt this will morph into standard of care without really appropriate levels of evidence to do so. So I'd say the same thing. If there's somebody that I can kind of, you know, tap on the shoulder in Hamilton, I would be happy to see our program get involved. And I can reach out to David in London as well. And really, I think for anybody on the line, that's in part what this is about, which is establishing these contacts and trying to pick up on the trials that you think are important and that your center can really help push recruitment. I'm a little bit nervous that if it's even a little bit difficult in BC, it will be even more difficult in Ontario, but it's very encouraging to see those numbers out of London, as you say.
Totally.
Any other questions for Dr. Olson? I think you're a free man. I'll look forward to Caro.
Okay, thank you.
So our third speaker is Dr. Perry. Can I tease you about probably being the most famous medical oncologist in the country?
Not even a med-onc.
I know, well, neuro-oncologist, but and so this is, I appreciate stepping out of your fame a little bit to talk to us about study with respect to melanoma. So from Odette in Toronto, this actually finishes off our tour across the country, but I'll leave it to Dr. Perry to kind of go through his study with respect to the margins of melanoma.
Okay. Yeah, so there was a typo in the agenda. So this is an overview of the GBM AGILE trial. So this is a glioblastoma study, AGILE standing for Adaptive Global Innovative Learning Environment. What I want to do is try to focus this on the methodology involved, so that people can see how this could potentially apply to other cancer sites, and not spend so much time chatting about glioblastoma and the specifics of the drugs that are being selected and whatnot. It's really the methodology and the overview of how platform trials can be advantageous for oncology. So let's just get this slide here. This is a global effort. There are a couple of key concepts with these platform trials. You might know some of these previously, like I-SPY or the recent COVID REMAP trials. And the same organization that sponsors this trial, the Global Coalition for Adaptive Research, just announced today, actually, that there's going to be an ovarian cancer platform trial launched shortly. So some of the key aspects to this is that there's a master protocol that governs all of the methodology. And then as new drugs come on board to the study, they're considered protocol amendments. And so there's a big advantage that the bulk of everything is in the master protocol. So there's one major approval with regulatory, with ethics, etc. And then the newer arms come on the study and are just fairly simple protocol amendments. So it really accelerates the ability, rather than running 6 separate protocols with 6 different drugs. You're not submitting all of that work. It's all contained in the one clinical trial. And then the other part of it is that it's a so-called learning environment. And I'll go through this, but the study has adaptive randomization. So over the course of the study, the CRAs are going to have a tremendous amount of work, because each monthly visit is updated into the central statistical network for the clinical trial. And then in real time, events are captured and the performance of the arms are compared to each other. And the better drugs are going to be adaptively randomized in favor of them, and the lesser performing arms are going to slowly randomize fewer patients to those arms until it reaches futility. So this is an international effort, as I said, with the master protocol, looking at overall survival. Some of these obviously can have different survival endpoints. In glioblastoma, unfortunately, median survival is so short that it doesn't take very long to collect events, and our significant trials are all based on OS rather than any interim points. So it involves an initial stage of learning where the adaptive randomization takes place, and then if drugs graduate beyond certain pre-specified targets for success, then they graduate into what's essentially a phase 3 trial for the purposes of regulatory filing. GCAR, the Global Coalition for Adaptive Research, is the sponsor. It's a not-for-profit organization, so the pharma is not the sponsor of these. It's GCAR, and some of the people involved are listed there. People will likely have already run across Don Berry from Berry Consultants, who's one of the masters of biostatistics and protocol development, and he's been involved in all of these platform clinical trials. The clinical trial arms have PIs that are responsible for obviously writing the protocol and shepherding it through, and there's leadership both clinically in Europe, US, myself for Canada, an imaging lead, RADONC lead, and a biomarker committee. So this is sort of a circle of life of a platform trial, and GBM Agile in particular. So in the top left, sort of orange, you see that's where a new patient will come in. And in these platform trials, the patients are assigned as a subtype. So a subtype could be something as simple as newly diagnosed, or first recurrence, or it could be third recurrence, or it could be a molecular definition. So it could be ALK mutations, or it could be alterations in BRAF, but they're identified in some way, whether it's clinical at a certain time or an actual molecular biomarker. And that obviously depends on the properties of the drug and the individual diseases. So the patients are screened for whatever they need to be screened for in terms of eligibility. For glioblastoma, it's MGMT promoter methylation, done centrally, and then they can be randomized into the study. And as you just go around the circle, the protocol continues worldwide. There's updated case report forms, essentially updating on progression status, is the patient still on drug, all of the toxicity assessments, all the quality of life assessments, and ultimately survival assessments, all updated into the longitudinal model. And then that's where the statistics come into play to decide decision rules about whether a particular arm of the study needs to stop for futility or stop for toxicity, or graduate to an expansion, basically an expansion cohort, which is considered phase 3. And then in the bottom left of that picture, updating the probability of the efficacy of success, or the probability that the hazard ratio is less than 1 of the experimental drug versus control. And then the randomization probabilities vary according to the best performing arm. So that's the basic sort of structure. This might be a little small, but top left shows, when one of these platform trials starts. This is a hypothetical one with 3 arms with 3 different drugs and C for control. So at the beginning, they all start equally and they have equal randomization. So 1 in 4 chance into those. And on the right there, snapshot 2, down the road, as patients have accrued, you see that there's a different performance in the arms. So arm 1 seems to be dropping, so there are fewer patients. If you see the little stick figures at the top, there are fewer patients that are enrolled into that arm, and arms 2 and 3 doing a little better, getting more patients randomized to it, but always the same number to control, so the control stays consistent through the study. And then bottom left, snapshot 3, there are boundaries, the green and the red, for superiority versus inferiority. And drug 1 there falls out because of poor performance reaching the inferiority criteria, and it drops out of the clinical trial. And then the illustration in the other corner is drug 2, which is getting more and more patients randomized to it in favor, eventually graduates from the clinical trial. So the schema currently involves 3 experimental drugs that are listed there, and standard of care arm. And we're accruing newly diagnosed patients divided by biomarkers and recurrent patients. And they're randomized right now to the 4 arms, either standard of care, regorafenib, paxlovid, and validate 3, and there's equal probabilities more or less right now because the trial's just beginning. And then 3 new drugs are coming in early 2022. And they'll go through the cycle that I've described about assessment and real-world updating of data, etc. You can see one of the challenges, and I'm not sure how we're going to manage. I think we'll just have to learn as we go, is sitting down with the patient and explaining this. So, for this disease, it's so devastating for patients to hear. I mean, every cancer is, but patients at the beginning, it's hard to explain and clinical trials for patients with newly diagnosed GBM, because they're just they're really just spun and not absorbing everything. Later on, over time, almost everyone develops a good knowledge of things and then gets a little more desperate for better treatments. So one of the problems is just going to be at that initial consultation, explaining a clinical trial with potentially 7 arms with 6 different drugs, and the drugs all have different mechanisms of action, so different toxicities. Some are going to have hand, foot, skin things, hepatitis, myelosuppression. Some of them are intravenously delivered, some are oral. So it's going to be a very hard thing to explain to patients, and obviously a very complex structure for our research assistants to follow, and it creates some pressure on planning, chair time, systemic therapy time, because you don't know until the patient's randomized. So you have to prepare them for any one of the particular drugs that they might be randomized to. This is probably self-evident, but there's an arm selection committee. So if there's interest in bringing in a new drug to the trial, and this is fairly common because this infrastructure is very attractive to, especially to small pharma, biotech, because the infrastructure is provided by GCAR. So the companies are only providing drug, and this entire process has already been, pre-registered in essence with regulatory authorities, with FDA, for example. So they'll want to put their drug into these studies, and the machine circles around and determines if they're going to be ready to file a new drug application. And it happens very quickly, especially with the efficiency of always having the same control group in the study that applies to each of the arms. So there's much fewer patients that are required in the control arms because it's just one for the other 6 drugs, as opposed to having 6 control arms in 6 different studies, right? So it's better for patients because they're much more likely to be randomized to an experimental arm than a control standard of care arm. And as the trial goes on, they're more likely to be randomized to an active drug as opposed to an inactive drug. I think I've said this stuff about the final, and so the final analysis comes as is typical after we've reached the statistical survival point, and then drugs move forward. One other complication, and I'll stop here, is for us is imaging is complex. And we've devised a new schema that will apply all through the platform, which allows us to incorporate so-called pseudoprogression or treatment effect, which is pretty common with a lot of these drugs. So you'll get this inflammatory effect, much like you would see with immuno-oncology drugs, and you might see some transient worsening of the imaging. So we've built in a way to identify so-called pseudoprogressions so the patients can continue on the drug in the clinical trial until true disease progression is confirmed. And that's going to be one of the challenges for us because these MRIs are happening frequently, as often as Q6 weekly, and we need to have these measurements and everything incorporated and uploaded into the database on the day we see them. So I'll end there and take any questions.
Thank you very much. So again, maybe the lesson learned for myself is if something doesn't make sense, maybe ask an additional question. So I won't ask anything about surgical studies. There is a bit of a parallel, though. The studies that I'm aware of at the CCTG are very similar in the sense that they have an LY17 and an LY18, and 18 is really looking at the toxicity component and then basically maturing to the 17, which is similar in the sense that it's a pick the winner sort of strategy, if you will. I think the point is well taken. This sometimes becomes a bit of a difficult exercise with patients. And I think sometimes the other piece is just that study in particular with CCTG has at times had, kind of stop and go from a regulatory update kind of perspective. So it'd be interesting to see even what you learn with how Health Canada kind of sees this going forward as some of your data starts to mature.
Yeah, I agree that that'll be the operational challenge because these updates, these are going to be protocol amendments, and we may have hold put on accrual in particular arms for that reason. So yeah, we'll see. We'll learn. It's been open in the U.S. With just 2 arms for a while before us, about a year. So there have been about 800 patients screened and about 300 randomized into the study, and the 4 arms are now opening all over the place, including the Canadian sites. So we're looking forward to it. This will be the backbone of everything we do in this disease space for probably 5 to 10 years.
Yeah.
Yeah.
Well, I'd say first that ratio of 300 out of 800 actually sounds pretty good. And again, I think for diseases where outcomes are not very good, this makes a lot of sense to try and expedite, drug discovery as opposed to one at a time. So.
Absolutely.
Well, I don't see any other general questions. So again, thank you very much for the presentation. Again, as I've said before, I think investigators have come forward with these presentations to try and solicit interest. So if there's any questions that people want to kind of direct, we can do that after the fact electronically, and I'm sure they'll be happy to answer any questions even after the formal kind of 2-day meeting is done. So thank you very much.
Sure. Thank you very much.
Thank you very much, Dr. Wright, for facilitating the session, and also thank you for all the wonderful speakers. And thank you for all the participants that joined today's session.